I'm here to talk on the femoral reconstructions in complex and revision scenarios. You get femoral deficiency due to various reasons. It can be due to osteolysis in aseptic loosening, wear, or infection, or it can be a perforation of the component, or it can be a surgical window, or the external trochanteric osteotomy which you do, or it can be a stress shielding which can go for osteoporosis, and severe osteoporosis per se can cause a lot of problems. In addition, any fractures or any deformities in the bone again is a problem when you come for the femoral component placement. So the general understanding is whether you have a segmental defect or you have a cavitated defect. So this is the most important differentiation. And segmental defect can be unicortical or bicortical, or can be four cortex involvement. Then you say it's complete segmental involvement. A cavitated defect is just a cavity which is contained, so easy to treat. And you need to understand that any defect above the lesser trochanter is easy to treat. Below the lesser trochanter up to 10 centimeters is another area, and beyond 10 centimeters again is a big issue. So there is a classification for understanding and also what component to place. So Paprosky's classification gives a good idea. And type 1 defect is nothing but the minimal metaphyseal defect just above the lesser trochanter. If the metaphysis is too much of involvement and you need to depend on the diaphysis, is type 2. And when you come to type 3, we have a metaphysio-diaphyseal defect, but still the diaphysis is more than 4 centimeters intact for a scratch fit. If you have less than 4 centimeters for a scratch fit in a diaphysis, is type 3B. And type 4 is the stovepipe appearance, very thinned out cortex, no very large medullary canal. So these are the things which you should understand when you plan for a femoral component. In addition, as I said earlier, the femoral deformity like ectasia or bowing or varus deformity, all these also can influence the placement of femoral component. So how you look at it, where you need to classify the bone defects and also assess the biology, because when you think about uncemented, the bone need to grow into the porous material. So if the biology is not good, like for example the irradiated bone, you cannot use a uncemented hip. So understand the biology, whether it will work to heal the component, fix the component. So the implant selection, you go whether going for uncemented, cemented, monoblock, modular, or mega process or bone graft. So all these should run in your mind. And there are various types of implants, and you got a solid cylindrical uniform diameter, or you have a tapered fluted stem, or you have a bowed stem, modular type, so with the stem and also the body. So the most commonly used is for the diaphyseal fixation is the tapered fluted titanium stem. That's a Wagner type. It can be monoblock or modular. And the second commonest I would say is the fully porous coated cylindrical stem, like a solution stem. And also if you fix the proximal fixation, if you need, you can go for any of the conventional stems like fully porous coated or partially proximally porous coated stems, or you can go for a metaphysio-diaphyseal fixation using a SROM stem, which is the metaphysio-diaphyseal fixation. And we all know about the Wagner, the success story of Wagner SL revision stem. Again, the body varies whether you have a cone body or a calcar body or a spout body or XL body. So depending on the defect, you can manage accordingly. And coming to the long stems, the cylindrical stem, as I said earlier, the second example is the SROM stem, which is modular, and then the tapered fluted stem and the mega processes. So various different components, the femoral components you need to understand. When it comes to the principle, always the revision stem should bypass the most distal defect. That is very, very important. You cannot stop short. I know there are a lot of papers to say that you can stop short, like Zoimiller stem. He has proven that he's got a larger study that you don't need to bypass the defect. But I think in his stem it might work, but not in others. So always when you pass beyond the defect, it should be double the cortical diameter. So that is again very important. That means at least 5 centimeters it should cross beyond that point. So longer the stem, it has got a good resistance to the torque. So torque resistance is better if you put a longer stem. And also you get a better rigid fixation to start with. And always uncemented stems are preferred because the long-term survival is much, much better. So there are two types, as I said earlier. One is the cylindrical, fully porous, the coated stem. The other one is the tapered fluted titanium stem. The cemented revisions always have a high failure rates, so it doesn't last long, but it is a choice when it comes to the very elderly, osteoporotic, or you want the patient to be on their feet on day one. For many reasons, you may need to do a cemented stem. So you need to have a good preoperative plan, the type of implant, the proximal body support, what you're going to aim for, the component size, and the joint biomechanics you need to restore, so the leg length and the offsets. So when it comes to defect management, the large defects like contained defect, as I said earlier, you can go for impaction bone grafting. You can use a structural stud graft to support if it's a cortical defect, or you can use a mesh graft. So this is a impaction bone grafting. When you go for impaction bone grafting, you should have a good technique, and you should have the femoral heads can be mashed for the impaction. And in the previous days, when I was in Manchester, we used to do a lot of impaction bone graft, the proximal femur. We remove the cemented component and then put an impaction bone grafting, and again a cemented long stem revision we used to do. In our country, I have not done one. So if there's a cortical femoral defect, the defect can be closed either with a plate on the side, or you can use a mesh and with a circlage wire, and then you can use the cemented long stem. But I think it's all become historical now. When there is a large segmental defect, then you need to fill the gap with a metallic endoprosthesis like a megaprosthesis, or sometimes you need to think about the bulk allograft composite. So this is a typical example of the whole proximal femur has been taken off because of the tumor, and you go for the megaprosthesis. So the bulk allograft technique is an alternative, but if you have an access for the whole femur, you can cement it on the allograft, and then the allograft composite you can attach to the host bone with a plate or plate and screws, and then you should have a rigid fixation. So coming to a few examples, the type 1 defect of the Peprowskis, where, as I said earlier, only minimal metaphyseal problem. Here we use the Zweimüller stem to fix get an uncemented fixation. So that is very easy. And this is a very elderly lady, had a failed trochanteric fixation, and with a type 1 defect again. Here this patient should be on the feet from day one. We cannot be bedridden for another few weeks. So cemented stem was preferred. This is a type 2 defect. Here, this is a DDH which lasted for 12 years, and then we need to revise this stem, and we used the metaphyseal diaphyseal fixation using the SROM stem because the medullary canal was so narrow. And this is a type 3A defect. Again, they can see the component sinking in, and we need to use a trochanteric osteotomy to get the component out, and then the cylindrical solution stem was used here, the collared stem, for fixation of these femur. This is a perforated stem with loosening. So you need to bypass the graft, bypass the distal perforation. So this is the typical type 3A. Most of the external trochanteric osteotomies are type 3A. So it is similar to that. So you have a scratch fit in the distal 5 centimeters, and then you can get a good fixation. This is a very, very elderly lady, nearly 85, many revisions done, and so this we did a long. This was the whole thing was taken off as like a Dorsey type, so the long stem cemented revision was done here. This is a re-revision case, so thrice done in 30 years down the line, and you can see at the distal part of the stem, the bone is going for remodeling with a varus deformity. So you need to do an osteotomy to get it straight, and then remove the cement which is going beyond the point of the tip of the stem for a few centimeters. So this is like a type 3B, where less than 5 centimeters was there, but we could get away with a Wagner's long stem revision. So this is a 14 years follow-up, and this is she had a periprosthetic fracture in the time, and 20 years follow-up. Now she's doing very well without much of an issue. No problem with the component. And the implant failure, so here we need to remove the implant and do an external trochanteric osteotomy, and then again the same uncemented tapered fluted stem was used. Here, here only cortical window was done distally to remove the stem. The proximally it was pulled out, and then we were able to, only the cortical window was closed, and the tapered fluted stem was used. So similar situation here as well. Um, this is again a young male, had a dislocated hip for many years. He was walking on it, and you can see the distal femur was a malunited fracture. At this time of the fracture, he dislocated his hip, but he ignored it, and we need to find fixation which will fix in the middle of the diaphysis. So we had only 4 to 5 centimeters to play around, and a thick short stem was used to get away from the problem, and the trochanter was again wired back. This is an osteopetrosis lady who had multiple surgeries done for neck of femur, subtrochanteric fracture, failed implant inside, and when she had a revision, she had a MI on table, so I need to close it and then come back again after a few weeks, after 6 weeks down the line to go back. So without any we removed the whole of the proximal femur. We were able to get away with a good fixation, with the good orientation of the component, and the trochanter was wired back, and she was able to walk independently. This is a 4 months follow-up. So you have different options, and this is a Dorsey type 4, and you can see very wide stovepipe appearance. So here we removed the component, and then we didn't try to remove the cement distally. We tried to fit in with a cemented short stem and got out of the problem. Sometimes you need to use a long stem like this, the exceeded long stem cemented to get a fixation Dorsey type 4, Kaprowski type. Here again, a very 85-year-old, 130 kilos weigh. She was bedridden for 3 months. So you need to have something which she can walk on from day one. So we did the osteotomy on the distal end, and the external trochanteric osteotomy with a window, and we need to use the cemented double packet cement was used, and got a cemented long stem. So to conclude my talk, the type 1 can be managed either with cemented or uncemented depending on the indication, with the primary stem itself. In type 2, you need to have a metaphyseal diaphyseal fixation, so calcar replacement stems may be preferred to restore the limb length. And type 3, A or B, whatever, the best one I would say is the fluted tapered titanium stem like Wagner. And some in US they tend to do the cylindrical porous coated stem like Solution. In type 4, impaction bone grafting is the better option. Otherwise, you need to select the allograft prosthetic construct or modular tumor processes, or sometimes cemented long stem processes. So thank you, everyone.